My name is Abby Phelps, and I will be going over distributive shock, and this is my third video. So, distributive shock or vasodilatory shock is a medical emergency where your body can't get enough blood to your heart, brain, and kidneys. This happens because your blood vessels are extremely dilated, which brings down your blood pressure and cuts down on how much blood can get to your organs. Often, the small blood vessels are leaky in distributive shock, resulting in some fluid loss from the circulation. So, some common findings that you would find in distributive shock, a skin rash. So, I have an image over here. This is actually an image of someone that had distributive shock. Increased heart rate and breathing. Typically have a low blood pressure, your arms and legs could be warm. Skin that starts out warm and then it can eventually turn cold and clammy. Fever, chills are very common. Pain in belly, confusion, shortness of breath, nausea, and throwing up are common findings with distributive shock. So, imaging for suspected distributive shock. So a chest x-ray should be completed first if a patient has potential for sepsis, cough, chest pain, or dyspnea. A chest computed tomography, a CT scan with or without contrast should be performed if further imaging is required following a chest radiograph that are normal or non-specific. CT scanning has become the diagnostic test of choice for suspected intra-abdominal causes of sepsis. Consider abdominal and pelvic CT scans with intravenous contrast if these sites are found to be clinically suspicious for infection. Point of care ultrasounds and ECGs may be performed at bedside in critically ill patients to evaluate cardiac function, fluid status in response to hemodynamic intervention. Right. So here's an image that I found for distributive shock. So this is actually an 8-year-old boy that developed septic shock secondary to pneumonia. Fungal infections are also rare because of septic shock. So you can see kind of the consolidation from the pneumonia in this photo. So hemodynamic monitoring and values. So basic monitoring that typically go through is heart rate through ECG or EKG. Usually your patient will be tachycardia to compensate for their decreased blood pressure, which goes to the next thing. Typically your patient's blood pressure will be low and they will have an increased respiratory rate. So they'll probably be in some distress. Pulse oximetry. So oxygen may be decreased due to impaired oxygen delivery to the tissues due to the patient being in shock. Temperature, it can go either way. It could be high or low. More invasive monitoring can be an ABG, an A-line to monitor their blood pressure and do frequent monitoring of their arterial blood gas. So central venous oxygen saturation can typically be low due to tissues extracting more oxygen than what is being delivered. A Swan GANS, as I said earlier, it's not as commonly used anymore, but the cardiac output can be high due to the body compensating for the low systemic vascular resistance. The systemic vascular resistance can be low due to vasodilation, and their pulmonary capillary wedge pressure can be either normal or low. and their CVP can be low due to vasodilation. Medications for distributive shock. So vasopressors are typically used to raise your patient's blood pressure, excuse me. Antibiotics if your patient does have an infection. Antihistamines if your patient has had an allergic reaction. Steroids for an allergic reaction are severe sepsis. Albuterol, common ones that we use and see often are Acunev and ProAir HFA if your shock is due to an asthma attack. So ABGs that you typically see for distributive shock. So there's early stage and late stage. For early stage respiratory acidosis, their pH could be high. PaCO2 is low. Their bicarb, excuse me, can be normal. And then in the late stage, it can slowly turn into metabolic acidosis to where their pH is low, their PaCO2 is low, and their bicarb is low. And their PaO2 can kind of vary from patient to patient. So mechanical ventilation for distributive shock, kind of similar to hypovolemic shock. Typically, you want a low tidal volume. 6 mLs per kilo is usually what is wanted. You want to maintain a plateau pressure below 30 centimeters of water and use appropriate levels of PEEP to prevent alveolar collapse. And respiratory rate can differ just depending on their PaO2. Specific concerns and positive pressure ventilation. So concerns that you can have with it is organ failure for patients with the more severe sepsis, brain damage due to decreased flow to the brain, and also heart damage due to decreased flow to the heart. Kidney damage is also common due to the decreased flow to the kidneys, which can lead to renal insufficiency. For positive pressure ventilation, it should be administered cautiously as it can sometimes worsen hypotension by reducing preload due to the increased intrathoracic pressure. Right. Summary, so physical exam findings, imaging, so chest x-ray, CTs, and ultrasounds are popular. Hemodynamics and monitoring, medications, we went over ABGs, vent settings to, you want to make sure that they're low for your distributive shock patient with low tidal volumes. And then we went over specific concerns and positive pressure ventilation. So distributive shock is a medical condition in which abnormal distribution of blood flow in the smallest blood vessels result in adequate supply of blood to the body's tissue and organs. All right.